Adult basic life support. See Figure 39.1. Figure 39.1 Resuscitation Council. Shout for help early, look for chest movement, listen for airflow and feel for a carotid pulse. If absent or uncertain, declare cardiac arrest and immediately call the resuscitation team. Gasping, agonal breaths and seizure. Light movements are common in the early moments after cardiac arrest and should not be mistaken for signs of circulation. Immediately start CPR, apply defibrillation pads, check the rhythm, and give a shock if VF or pulseless VT. VFPVT, follow the ALS algorithm. Chest compressions, give compressions at about 120/min at a depth of 5-6 centimeters in the lower half of the sternum. Allow full recoil of the chest. With equal time in compression and decompression, change the person doing compressions about every 2 minutes. Use a mechanical compression device if manual compressions are impractical, prolonged or during transport. Breathing, give 30 chest compressions. Before giving 2 ventilation breaths, use an inspiratory time of 1s and achieve a normal chest rise. Give the maximum inspired O2 feasible, when the patient's trachea is intubated. Give continuous compression at about 120/min and ventilate the lungs at 10 breaths min without pausing compressions. This can also be done with an SGA when there is a good set-L application of defibrillation pads. Analyze the rhythm using self-adhesive pads as soon as is possible. Continue chest compressions while placing the pads. Place one pad below the right clavicle and the other in the left mid-axillary line at the position of the V6 ECG electrode lateral to any breast tissue. Period. Ensure good adhesive contact with both pads. Alternative pad positions are AP or biaxillary. Pause briefly, 5s, to assess the rhythm. If shockable, VFPVT, restart compressions and charge the defibrillator during compressions. Once charged, pause the compressions and give shock. Immediately resume compressions. Check rhythm after 2 minutes of compressions. Suspected cervical spine injury, do not delay starting CPR when there is a risk of spinal cord damage. Untreated cardiorespiratory arrest will kill the patient. Minimize neck movement and try and keep the neck in a neutral position, but do not compromise resuscitation interventions. 1054 Chapter 39 Anesthetic Emergencies at Risk patients. All patients should have prior decisions about CPR to prevent inappropriate CPR attempts. Use an early warning scoring system to identify deterioration and escalate care. Further reading European Resuscitation Council. Adult Advanced Life Support. See Figure 39.2. Figure 39.2 Resuscitation Council UK. Adult Advanced Life Support Algorithm. Reproduced with the kind permission of the Resuscitation Council UK 1056. 1056 Chapter 39 Anesthetic Emergencies. High quality CPR. Ensure high quality chest compressions with minimal interruption. Aim for 5s for all pauses for interventions. Defibrillation, when a shockable rhythm, VFPVT, is seen. Restart chest compressions and charge the defibrillator. Pause to deliver the shock and immediately resume compressions. Ensure everyone is clear when shock is delivered. Use at least 150 joules in an adult. Follow defibrillator manufacturer's instructions. Escalate shock energy if initial shocks fail. Remove O2 face mask or bag valve mask to 1m. Leave O2 circuit connected for an SGA or tracheal tube. Continue compressions for 2 minutes until the next rhythm check. Use 3 stacked shocks. For a witnessed VFPVT where a defibrillator is immediately available, e.g., cardiac catheter lab, precordial thump has a low chance of success if no defibrillator available. Change pad position e.g., to anterior-posterior. If VFPVT persists. Airway management and ventilation. Assess and open the airway. Use head tilt, chin lift and or jaw thrust. Use an oropharyngeal or nasopharyngeal airway if needed. Use suction to clear secretions and gastric contents. Give 100% inspired O2 during CPR. After ROSC, target SpO2 94 to 98%. Use a stepwise approach. Bag valve mask, SGA or tracheal tube. Use whichever technique works best to deliver high-quality CPR with minimal interruption to compressions. When the patient's trachea is intubated, give continuous compressions at about 120/min and ventilate the lungs at 10 breaths min without pausing compressions. This can also be done with an SGA when there is a good set-L. Use waveform capnography to confirm correct tracheal tube placement. Remember, even in cardiac arrest, no trace equals wrong place. Use front of neck access for airway if unable to oxygenate. Drugs and cardiac arrest. Give 1 mg of adrenaline IV or IO every 3-5 minutes, 10 ml of 110,000 solution during cardiac arrest. For VFPVT, delay first dose of adrenaline until after the third shock. Give amiodarone 300 mg IV or IO after 3 shocks for VFPVT. Lidocaine 100 mg can be used if amiodarone is not available. Treat reversible causes. Use the 4H's and 4T's approach: hypoxia, hypovolemia, hyperkalemia, and other metabolic disturbances, hypothermia, thrombosis, tension pneumothorax, tamponade and toxins. Consider anesthesia-specific causes. Malignant hyperthermia, LA toxicity, bone cement implantation syndrome, CO2/air amniotic fluid embolism, anaphylaxis. Adverse drug reactions. Adult advanced life support 1057. Use ultrasound echocardiography if skilled to do so, if available. The use of extracorporeal circulatory support, ECMO, can be used to restore circulation and buy time to treat the underlying cause. Modifications during anesthesia. Alert the theater team and call for help early. Start chest compressions immediately. Discontinue surgery if no surgical cause. Initially give small incremental doses of IV adrenaline 50 micrograms. And use standard dosing of 1 mg every 4 minutes if required. Rapidly identify and treat reversible causes, e.g., airway problems, retraction and vagal tone, hemorrhage. Chest compressions can be started by compressing between the scapulae for patients in the prone position. If the patient is not supine, emergency repositioning is required into the supine position to continue resuscitation. Further reading: Resuscitation Council UK. Management of cardiac arrest during neurosurgery in adults. Emergencies.org UK. European Resuscitation Council. emerc.edu. Resuscitation Council UK. Emergencies.org UK. 1058 Chapter 39 Anesthetic Emergencies. Post-resuscitation care following cardiac arrest. ROSC is the first step in what may be a prolonged period of treatment. Unless the duration of cardiac arrest is very short, the patient will be unconscious and is likely to develop the post-cardiac arrest syndrome, which is associated with a marked systemic inflammatory response. The anesthetist may be expected to initiate treatment in the ED, the operating room, the critical care unit, or on the general ward. The aims of post-resuscitation care are to prevent a further cardiac arrest, define and treat the underlying disease process, limit organ damage, predict non-survivors. Prevention of further cardiac arrest, optimize oxygenation. If fully conscious following a short-duration cardiac arrest, give O2 via a face mask. Most patients will require assisted ventilation via a tracheal tube. After ROSC, once SpO2 can be measured reliably or ABG values are obtained, titrate the inspired O2 to achieve a saturation of 94 to 98% or PaO2 of 10-13 kPa. Provide ventilation to maintain normocarbia. Excessive ventilation will cause hypocarbia and may cause cerebral ischemia from cerebral vasoconstriction. Maintain sedation with a propofol infusion, combined with a short-acting opioid. Avoid hypotension. MAP, 65 mmHg. Target MAP to achieve adequate urine output, 0.5 ml/kgh, and normal or decreasing lactate. Correct electrolyte disturbances, particularly K+, Mg2+, and Ca2+. Control blood glucose. Treat blood glucose with insulin if it exceeds 10 mol/L. Maintain in the range of 4-10 mol/L. Define and treat the underlying disease process. Establish the patient's pre-arrest medical condition. Confirm correct placement of ED and exclude pneumothorax with CXR plus or minus ultrasound. Perform early echocardiography in all patients in order to detect any underlying condition and quantify myocardial dysfunction. Consider CT brain and CT pulmonary angiography. Limit organ damage. Street elevation on the 12-lead ECG is an indication for urgent coronary angiography and PCI if indicated. In patients without street elevation on the ECG, consider urgent coronary angiography if there is a high probability of acute coronary occlusion, e.g., patients with hemodynamic and/or electrical instability. Treat patients remaining comatose after ROSC with targeted temperature management. Maintain a constant target temperature between 32 degrees Celsius and 36 degrees Celsius for at least 24h. Avoid fever for at least 72h after ROSC in patients who remain in coma. Control seizures with propofol, benzodiazepines, levetiracetam or sodium valproate. Post-resuscitation care 1059 Prediction of non-survivors. About 8% of all those sustaining an out-of-hospital cardiac arrest will survive to hospital discharge. The figure for in Hospital cardiac arrest is about 23%. Short duration of cardiac arrest CPR achieves better neurological outcomes. Prognostication in unconscious patients is unreliable for at least 72-96H after ROSC. Ensure that sedative drugs have cleared and use multiple modalities, clinical examination, imaging CT and/or MRI, biomarkers e.g., neuron-specific enolase, and electrophysiology e.g., somatosensory evoked potentials, myocardial, neurological and other organ function may all improve slowly, given appropriate support over a period of time. At least 3-7D of intensive care should be considered in the comatose patient with ROSC following cardiac arrest. Further reading Nolan J.P. Bradycardia. See Figure 39.3, Figure 39.3 Resuscitation Counsel. During anesthesia, stop surgical stimulus e.g., eye retraction pneumoperitoneum. If bradycardia persists, give atropine 0.5 mg IV increments up to 3 mg. Repeat atropine every 3-5 minutes up to 3 mg. Alternatively, use glycopyrronium in 50-100 microgram increments. If ineffective, consider other drugs e.g., adrenaline 2-10 micrograms min IV or isoprenaline 5 micrograms min. Or temporary pacing. If transcutaneous pacing, check for electrical capture on the ECG and that there is an associated pulse. The patient may need analgesia and/or sedation. Start chest compressions and follow ALS algorithm if brady asystole that is unresponsive to treatment. Discuss early with cardiology regarding temporary transvenous pacing and/or urgent permanent pacemaker insertion if immediately available, even without adverse features. A period of recent asystole, Mobitz type 2 block, complete heart block and ventricular pauses. 3S is high risk. These patients need monitoring and consideration of pharmacological treatment or pacing. Consider reversible causes of bradycardia MI, AF, post-cardiac surgery, drugs, toxins, electrolyte abnormalities, hypothermia, hypothyroidism, hypovolemia, hypoxemia and infections e.g., Lyme. Specific antidotes: Ca2 plus channel blocker overdose, give 10% calcium gluconate 1-2G or 10% calcium chloride 3-6G over 10-20 minutes. Greek letter beta blocker overdose, give glucagon 3-10 mg IV, then 3-5 mg HIV. Consider high-dose insulin 1 unit kg bolus, followed by 0.5 units kgh. Digoxin toxicity, give digoxin antibody fragment, 1 vial binds 70.5 mg. Give digoxin antibody fragment, 1 vial binds 70.5 mg of digoxin. Antidotes: Ca2 plus channel blocker overdose, give 10% calcium gluconate 1-2G or 10% calcium chloride 3-6G over 10-20 minutes. Greek letter beta blocker overdose, give glucagon 3-10 mg IV, then 3-5 mg HIV. Consider high-dose insulin 1 unit kg bolus, followed by 0.5 units kgh. Digoxin toxicity, give digoxin antibody fragment, 1 vial binds 70.5 mg of digoxin. Further reading Kusumoto FM, shown for tachycardia. See Figure 39.4, unstable tachycardias. For sinus tachycardia, ensure adequate anesthesia and analgesia, check ABCDE. Rapidly correct hypoxia, hypovolemia and electrolyte abnormalities K+, Mg2+, in otherwise normal patients, a ventricular rate of up to 150/min is normally well tolerated. But patients with impaired function may decompensate at lower rates. For all tachycardias, assess for life-threatening adverse features, syncope, shock, myocardial ischemia and heart failure. If present, perform synchronized direct current cardioversion. Patient may need sedation GA. For direct current cardioversion, use 70-120J for atrial flutter and narrow complex tachycardia, and 120-150J for broad complex tachycardia and AF. If direct current cardioversion fails, give 300 mg IV amiodarone over 10-20 minutes, then reattempt direct current cardioversion. Follow this with 900 mg IV amiodarone over 24H. If cardiac arrest or pulseless VT, start ALS algorithm. If the patient is stable, aim to use pharmacological methods first line. There is usually time to seek expert help. Stable, regular broad complex tachycardia. This is likely to be VT or a supraventricular rhythm with a bundle branch block. Treat with amiodarone. Seek expert help. Stable, irregular broad complex tachycardia, likely AF with a bundle branch block. Most cases should be treated as AF. This may be polymorphic VTIE torsade de pointe, but this is likely to be seen with adverse features or cardiac arrest. Treat with magnesium sulfate 2 grams IV and seek expert help. Stable, regular narrow complex tachycardia. Sinus tachycardia is a physiological response. Identify the underlying cause and treat. Paroxysmal SVT-AV nodal reentry tachycardia and AV reentry tachycardia represents abnormal conduction pathways allowing rapid ventricular rate. Atrial activity is often not visible on atrial flutter with variable AV conduction presents as a narrow complex tachycardia. The atrial flutter rate is classically 300/min, and so a ratio of 2:1 conduction gives a ventricular rate of 150/min. Try vagal maneuvers. If ineffective, give IV adenosine, starting with 6 mg, then 12 mg, repeat 12 mg, if necessary. Consider 18 mg. Differentiating narrow from broad complex tachycardia can be difficult, especially at high ventricular rates. Vagal maneuvers or adenosine should slow AV conduction of an SVT, but not a VT tachycardia. 1063 Adult tachycardia Figure 39.4 Resuscitation Council UK, Adult tachycardia algorithm. Reproduced with the kind permit. Theophylline interacts with adenosine and tends to block its effect. Dipyridamole and carbimazole potentiate the effects of adenosine. Adenosine should be used with caution in WPW syndrome and should be avoided in asthmatics. Warn patients of the transient unpleasant sensation before adenosine administration. If adenosine is ineffective, try IV verapamil 5-10 mg or short-acting IV Greek letter beta blocker, esmolol or metoprolol. Do not use verapamil and a Greek letter beta blocker together. Stable, irregular narrow complex tachycardia. Narrow complex tachycardia in an unstable patient. Correct rate with a short-acting Greek letter beta blocker IV. Consider amiodarone or digoxin in heart failure. AF may require anticoagulation of the patient prior to cardioversion. Patients with AF, 48H. Discuss with cardiologists. Further reading European Resuscitation Council. merc.edu European Society of Cardiology. mscardio.org Resuscitation Council UK. MResus.org UK Severe hypotension in theatre 1065 Severe hypotension in theatre risk factors, preoperative fluid deficit dehydration, diarrhea and vomiting, blood loss, mediastinal hepatic renal surgery, blood loss and caval compression, pre-existing myocardial disease dysrhythmia, multiple trauma, sepsis, carcinoid syndrome with liver or lung tumor metastases bradykinin, ACE inhibitors and ARBs. Differential diagnosis, measurement error, clinical assessment and manual palpation of the distal pulse, while repeating NIBP. Check when pulsation returns against the monitor deflation figure. If using intraarterial BP, check the transducer height is at the level of the heart. Check peripheral perfusion. Warm peripheries may suggest sepsis. Raised intrathoracic pressure can be caused by a pneumothorax or capnothorax. During laparoscopic surgery where the diaphragm is breached by insufflated gas. If tension pneumothorax is suspected, particularly following central line insertion in IPPV, the trachea will be shifted away from a hyperresonant lung field, which will have diminished breath sounds. Neck veins may be engorged. Treat immediately by decompressing the pleural cavity with a large bore cannula placed in the second intercostal space in the midclavicular line, or a thoracostomy. Patient factors: hypovolemia, obstructed venous return, intrathoracic pressure, anaphylaxis, severe hypotension. Severe hypotension and theatre risk factors, preoperative fluid deficit dehydration. Factors: hypovolemia, obstructed venous return, intrathoracic pressure, anaphylaxis, embolus, cardiac failure and dysrhythmia, severe sepsis or septic shock. Anesthetic factors: action measurement error, excessive depth of anesthesia, high regional block drug error. O2. Look for cause: A, B, C, D. Trendelenburg if appropriate. IV fluid challenge, vasoconstrictors, inotropes. Treat cause investigations: ECG, ABGs, echocardiography, troponin, CXR 106. 1066 Chapter 39 Anesthetic Emergencies. Suspect hypovolemia if the patient has HR, 100 bpm, RR, 20 breaths min, capillary return, 2S, cool peripheries, collapsed veins, a narrow and peaked arterial line trace or marked respiratory swing on either CVP or arterial line trace. Dehydration may be indicated by thirst, a dry tongue and dark, concentrated urine, and elevated blood cell counts, urea, creatinine and electrolytes. Suspect cardiac failure if the patient has HR, 100 bpm, RR, 20 breaths min, Engorged central veins, capillary return, 2S, cool peripheries, pulmonary edema or worsening SpO2 with fluid challenge, suspect an embolic event e.g., gas thrombus cement fat amniotic embolus, if sudden DSPO2, DSPO2, loss of palpable pulse, PN rise in CVP, air or gas embolus likely if there is an open venous bed above the level of the heart. Suspect cement or fat embolus if temporarily related to intramedullary surgery or cementing. Suspect fat embolus or cement reaction in the presence of multiple bony injuries or long bone, drug-related, iatrogenic drug responses. E.g., in patients with porphyria, see pages 260-2, or histamine release and drug errors e.g., wrong dilution or LA toxicity, high central neural blockade including unexpected central spread from peribulbar interscalene. May be heralded by Horner's syndrome, small pupil, ptosis, stuffy nose, anhidrosis, anaphylaxis, hypotension first feature in 46%, bronchospasm high airway pressure, 18%, tachycardia 9.8%, cyanosis O2 desaturation, 4.7%, bradycardia 3%. Reduced absent capnography trace, 2.3%, and cardiac arrest 1.2%. Immediate management ABCDE, check what the surgeons are doing, caval compression blood loss high pneumoperitoneal pressure. Prevent further blood losses by clamp or direct pressure, administer high FiO2. Maintenance of organ perfusion and oxygenation is more important than achieving BP alone. BP equals SVRXCO, therefore, improvement in CO equals stroke volume XHR may help ameliorate low perfusion pressure. Call for help early, including asking for massive hemorrhage protocol if bleeding. Optimize preload. If CVC cited, observe change in CVP from baseline in response to fluid challenges. Trend is more informative than actual number. Lifting the legs to 20 degrees, passive leg raise, or the Trendelenburg position, returns blood into the central venous compartment, thus increasing stroke volume. Fluid challenge of 10 ml kg of crystalloid colloid, using a vasopressor infusion, give blood and blood products for massive hemorrhage. Correct coagulopathy. Give tranexamic acid severe hypotension in theater 1067. After each intervention, assess response, BPHR CVP, and repeat if appropriate. Increase contractility, ephedrine 6 mg IV mixed direct and indirect action, adrenaline 10 micrograms IV Greek letter beta 1, 2 and Greek letter alpha activity, consider calcium slow IV up to 10 ml of 10% calcium chloride. Systemic vasoconstriction. Note, Greek letter alpha agonists increase perfusion pressure but may reduce CO. Metaraminol 1 to 2 mg IV. Phenylephrine 0.25 0.5 mg IV. Adrenaline 10 micrograms IV. Noradrenaline infusion. Subsequent management. 12 lead ECG and troponin to check for myocardial injury. FBC-ABG HemoQ registered sign to check for anemia. Correct acidosis to improve myocardial response to inotropes. Check ABGs, and correct respiratory acidosis first. If a severe metabolic acidosis exists arterial pH 7.1, basics S10 mol/L, consider using bicarbonate 50 mol, 50 ml of 8.4% sodium bicarbonate, maintenance infusion of vasoconstrictor e.g., adrenaline or noradrenaline, or inotrope e.g., dobutamine, if required. Other considerations, adrenaline 110,000 equals 100 micrograms ml, dilute in 10 milliliters of 0.9% sodium chloride to get a 100,000 solution, 10 micrograms ml. Patients taking Greek letter beta blockers may not demonstrate tachycardia. Despite significant hypovolemia, 1068 Chapter 39. Severe hypertension and theater risk factors. Consider inadequate depth of anesthesia, analgesia measurement error, hypoxia, hypercapnia, iatrogenic drug error, pre-eclampsia, raised ICP, thyroid storm, pheochromocytoma, carcinoid syndrome, action stop surgery. Consider inadequate depth of anesthesia, analgesia measurement error, hypoxia, hypercapnia, iatrogenic drug error, pre-eclampsia, raised ICP, thyroid storm, pheochromocytoma, carcinoid syndrome, action stop surgery until controlled, confirm readings, increase depth of anesthesia and analgesia, vasodilators, Greek letter beta blockade, Greek letter alpha blockade. Calcium channel blockers as required, investigations, ECG, troponin, thyroid function tests. 24H urinary catecholamine metabolite excretion or plasma catecholamine metabolites, severe hypertension in theater 1069, immediate management, ABCDE approach. Identify and treat the underlying cause. Keep calm and aim for an acceptable safe BP value based on patient's age and comorbidities. Avoid alternating between severe hypertension and severe hypotension. The aim is to minimize myocardial stress leading to MI, arrhythmia or failure Takotsubo cardiomyopathy, and to minimize the risk of hypertensive stroke and surgical bleeding, if difficult BP to control. Insert an arterial line for continuous BP monitoring early. Consider the following drug options to decrease SVR and control HR. The choice of drug will depend on availability. Vasodilators may cause tachycardia, high volatile concentration, but beware of increasing desflurane which may cause sympathetic activation at 1.5 mAh. Hydralazine 5 mg slow IV every 15 minutes. GDN 50 mg/50 ml, start at 3 ml/h, and titrate to BP or sodium nitroprusside, 50 mg/50 ml and titrate with care for fine control. Magnesium sulfate 2-4G slow IV 8-16 ml, over 10 minutes, followed by infusion of 1 gh, Greek letter beta blockade, particularly in the presence of IHR or dysrhythmias, esmolol 25-50 mg bolus doses, then 50-200 micrograms kg minimum. Note that esmolol is supplied as 10 mg/ml in 250 mg/ml solutions. Labetalol 5-10 mg IVPRN 1-2 ml increments from a 100 mg/20 ml ampule. Greek letter beta, Greek letter alpha block ratio equals 7:1. Greek letter alpha blockade, particularly in the presence of normal or DHR. Phentolamine 1-2 mg IVPRN 10 mg ampule made up to 10 ml, calcium channel blockade with IV nicardipine in 2.5 mg increments. Subsequent choice of drug will depend on availability. Vasodilators may cause tachycardia, high volatile concentration, but beware of increasing desflurane which may cause sympathetic activation at 1.5 mAh. Hydralazine 5 mg slow IV every 15 minutes. GDN 50 mg/50 ml, start at 3 ml/h, and titrate to BP or sodium nitroprusside, 50 mg/50 ml and titrate with care for fine control. Magnesium sulfate 2-4G slow IV 8-16 ml, over 10 minutes, followed by infusion of 1 gh, Greek letter beta blockade, particularly in the presence of IHR or dysrhythmias, esmolol 25-50 mg bolus doses, then 50-200 micrograms kg minimum. Note that esmolol is supplied as 10 mg/ml in 250 mg/ml solutions. Labetalol 5-10 mg IVPRN 1-2 ml increments from a 100 mg/20 ml ampule. Greek letter beta, Greek letter alpha block ratio equals 7:1. Greek letter alpha blockade, particularly in the presence of normal or DHR. Phentolamine 1-2 mg IVPRN 10 mg ampule made up to 10 ml, calcium channel blockade with IV nicardipine in 2.5 mg increments. Subsequent management, pheochromocytoma crisis, or thyroid storm, may require prolonged treatment and ICU admission. Liaise with endocrinologist to ensure the correct samples are taken for investigation, and further treatments e.g., antithyroid drugs, iodine, steroids for thyroid storm. Check for evidence of MI and myocardial injury. Troponin, 12 lead ECG. Echocardiography, patient may require longer-term medication for BP. For pheochromocytoma, this includes an Greek letter alpha blocker, phenoxybenzamine or doxazocin, and if they have tachycardia, a Greek letter beta blocker. 107 1070 Chapter 39 Anesthetic Emergencies. Severe hypoxia in theater. Risk factors, reduced FRC. Obesity, intestinal obstruction, pregnancy. Reduces O2 reserves. Failure to preoxygenate exacerbates airway difficulties at induction. Laryngospasm can result in negative pressure pulmonary edema. Head and neck surgery, shared access to the airway. Increases the risk of undetected disconnection. History of CHD or detection of a heart murmur. Left to right communication. Chronic lung disease. Methemoglobinemia interpreted as deoxyhemoglobin by pulse oximeters. Systemic absorption of patent blue dye. Differential diagnosis, inappropriate FiO2, use an O2 analyzer at all times, signal error, reduced peripheral perfusion in hypovolemic, hypotensive, hypothermic patients or AF, Raynaud's. Does the patient appear cyanotic? Obstruction of airway equipment, check for kinks e.g., during positioning of gag during tonsillectomy, foreign bodies and filter at, water in circuit, ventilation problem, is at same depth as it was? Has it been dislodged? Look for chest movement with auscultation over the stomach and in both axillae. Is the patient hyperventilating? Look at minute ventilation equipment problems, incorrect flow meter settings, machine or O2 failure, disconnection, inadequate peripheral perfusion, failure to ventilate, shunt hypoventilation, misplaced at airway obstruction, airway resistance, DFRC, atelectasis, airway secretions, D, hypoxic pulmonary vasoconstriction, pulmonary edema, aspiration of gastric contents, blood existing pathology, poor O2 delivery, systemic hypoperfusion, embolus, action 100 O2, call for help, check airway and ventilation, lungs to machine, check for cardiovascular cause, investigations, SpO2, cap, severe hypoxia and theater, risk factors, reduced FRC. Equipment problems, incorrect flow meter settings, machine or O2 failure, disconnection, inadequate peripheral perfusion, failure to ventilate, shunt hypoventilation, misplaced at airway obstruction, airway resistance, DFRC, atelectasis. Airway secretions, D, hypoxic pulmonary vasoconstriction, pulmonary edema, aspiration of gastric contents, blood, pre-existing pathology, poor O2 delivery, systemic hypoperfusion, embolus, action 100 O2, call for help, check airway and ventilation. Lungs to machine, check for cardiovascular cause, investigations, SpO2, capnography, temperature, CXR, ABG, FOB, severe hypoxia in theater 1071. Common after opioids or insufflation of abdomen during laparoscopy. Take note of the insufflation pressure. Has the capnograph waveform changed, indicating obstruction, restriction or hypoperfusion? Has the peak ventilatory pressure changed? Common in Trendelenburg position, laparoscopy or endobronchial placement of ET, airway resistance, laryngospasm, bronchospasm, aspiration, airway secretions, aspirate with tracheal suction catheter, tension pneumothorax, suspect. Particularly following CVC insertion and accompanied by cardiovascular signs, hypovolemia, HR, 100 bpm, RR, 20 breaths min, capillary return, 2S, cool peripheries. A narrow and peaked arterial line trace or marked respiratory swing to either CVP or arterial line trace. Quantifiable using ppv, 10% suggests hypovolemia, cardiac failure, HR, 100 bpm, RR, 20 breaths min, engorged central veins. Capillary return, 2S, pulmonary edema or DSPO2 with fluid, air or gas embolus, pre-existing low CVP and open venous bed. Signs include sudden DSPO2, DSPO2, loss of palpable pulse, PN, subsequent rise in CVP, other embolic events, thrombus, cement, fat, amniotic fluid during at-risk surgery, intramedullary surgery, cementing, obstetrics. Cardiac shunt, e.g., VSD, ASD plus DSVR with reversal of flow, MH, especially if accompanied by IETCO2, IRR, IHR and ectopics, anaphylaxis, CVS collapse, bronchospasm, angioedema, erythema, rash, urticaria, second gas effect. Especially in recovery after using N2O. Immediate management, administer 100% O2. ABC, manual ventilation gives tactile feedback. Perform recruitment maneuver, e.g., 30 cm H2O for 40s. Be alert for cardiovascular effects, e.g., hypotension during recruitment. Expose the chest, breathing circuit and airway connections. If steep head down, consider supine position until hypoxia resolved. Bronchospasm, treat by increasing the volatile agent concentration in IV salbutamol, 250 micrograms. Sometimes no wheeze will be heard as bronchospasm severely limiting air entry. Eliminate ET obstruction by gently passing a suction catheter through, then treat as above. Misplaced ET, confirm ET position at teeth, and look for rise and fall of the chest with auscultation over the stomach and in both axillae and the capnograph trace. Direct or videolaryngoscopy to ensure ET through cords. Ruling out equipment problems, switching to self-inflating bag with alternative O2 supply immediately rules out machine and circuit problems, but ensure means of keeping patient anesthetized without inhalational agent. This does not rule out problem with ET or filter HME. If in doubt about the inspired O2 concentration, use a separate cylinder supply. The source of a leak or obstruction is not as important as oxygenation of the patient. Make the patient safe first, then use a systematic approach. 1072 Chapter 39 Anesthetic Emergencies, Hypotension, Hypovolemia. Use fluid blood vasopressors as needed. During laparoscopy, check insufflation pressures and ask surgeon if they can be reduced if needed. Severe right-to-left shunt. Severe hypoxia occurs when blood starts flowing through a congenital heart defect in the presence of low SVR, thus bypassing the pulmonary circulation. The resultant hypoxemia exacerbates the problem by causing hypoxic pulmonary vasoconstriction, which increases PVR and the tendency for blood to shunt across the cardiac defect. Treatment is therefore twofold: 1. To increase SVR by lifting the legs Trendelenburg and giving adrenaline plus IV fluid, especially in sepsis, and 2. To minimize PVR by removing PEEP, avoiding high intrathoracic pressure and maximizing FiO2. Other considerations: in chronic bronchitis, the bronchial circulation can shunt up to 10% of the CO. The foramen ovale remains patent in 20 to 30% of patients but is normally kept closed. Because the left atrial pressure is usually higher than the right atrial pressure. IPPV, PEEP, breath holding, CCF, thoracic surgery and PE can reverse the pressure gradient and result in shunt. Always check the SpO2 probe is well positioned and has a good trace. However, this should not be presumed to be the offending problem until other causes have been excluded. Severe laryngospasm. 1073. Severe laryngospasm risk condition: acute glottic closure by the vocal cords, presentation crowing or absent inspiratory sounds and marked tracheal tug, immediate action 100% O2, CPAP, Larson's maneuver, vigorous jaw thrust, remove irritants from the airway, deepen anesthesia, follow up action, muscle relaxation if intractable. Also consider bronchospasm, laryngeal trauma, airway edema, recurrent laryngeal nerve damage, tracheomalacia, inhaled foreign body epiglottitis. See Rope 1074 Chapter 39 Anesthetic Emergencies, Air gas embolism. See also pages 584-5. It is claimed that symptoms, signs of an air embolus appear following 0.5 ml kg min of intravascular gas. Risk factors: patient, spontaneously ventilating, negative CVP, patent foramen ovale, risk of paradoxical emboli, anesthesia, hypovolemia, any open vascular access point, operation site higher than the heart. Pressurized infusions, orthopedic surgery, multiple trauma, long bone surgery especially intramedullary nailing, hip surgery, shoulder surgery and beach chair, general surgery, laparoscopic procedures, hysterectomy, neck surgery. Vascular surgery, middle ear procedures, neurosurgery, posterior fossa operations in the sitting position, almost historical. Diagnosis: high index of suspicion is needed in the at-risk patient. Respiratory: dramatic fall, loss of the ETCO2 trace and fall in SpO2. CVS: severe chest pain if awake, tachycardia, arrhythmia. Sudden ICVP due to fall in CO and rise in PVR. P arrest may occur. ECG may show signs of acute ischemia, e.g., S-segment depression of 1 mm, neurological, CVE-like symptoms, failure to wake up. Classically, a millwheel murmur can supposedly be heard. Doppler ultrasound can detect 0.25 milliliters of air. Condition: venous gas produces an airlock in RV and obstructs pulmonary capillaries. Presentation: DETCO2 DSPO2, hypotension and loss of palpable pulse ICVP, then DCVPP. Immediate action: stop insufflating gas, ensure open wound lower than heart, flood wound and compress drainage veins. Follow up action: I venous pressure, turn off N2O, left lateral head down tilt. CVS support investigations: auscultation, Doppler, ECG. CXR. Also consider breathing circuit disconnection. Other causes of P, 4Hs and 4Ts, cement reaction, pulmonary thromboembolism. F. Air gas embolism. 1075 Immediate management ABC, eliminate possibility of breathing circuit disconnection, give 100% O2. Check the ECG trace and pulse, increase venous pressure with rapid IV fluids plus or minus vasopressors. If P arrest occurs, commence the ALS protocol for non-VFVT cardiac arrest. Prevent further gas air entrainment. Surgeon to apply compression to major drainage vessels. Flood the surgical field with irrigation fluid or cover with damp pack. Stop reaming, etc. Decompress any gas pressurized system cavity, e.g., the abdomen during laparoscopy. Lower the operation site to below the heart level. Turn off N2O. N2O will expand any intravascular gas volume. Central venous line. Classic teaching is to tip the patient head down in the left lateral position, to keep the bubble of gas in the right atrium or apex of the RV. It can then be aspirated via a central line advanced into the right atrium or will eventually dissolve. In practice, even if a CVP line is in situ, aspiration is likely to be difficult. Moderate CPAP, advocated as a means of rapidly increasing the intrathoracic pressure, and therefore CVP, in the event of a gas embolus. While this maneuver may limit the extent and progress of an air embolus, it must be borne in mind that 10% of patients may have a patent foramen ovale. Sustained rise in right atrial pressure may then lead to a right-to-left shunt and paradoxical air embolism to the cerebral circulation. Subsequent management: ask the surgeon to apply bone wax to exposed bone edges, correct any pre-existing hypovolemia, perform a 12-lead ECG to look for ischemia. Air in coronary arteries is suggestive of paradoxical air embolism. Consider hyperbaric therapy. If available, ambient pressure, 3-6 bar, will decrease the volume of gas emboli. Other considerations: CO2 is the safest gas to use for laparoscopic insufflation. It is non-flammable and more soluble than other agents. Should a gas embolus occur, it will dissolve over time. The priority of management should therefore be to limit the extent and central progress of the gas bubble, thereby minimizing its systemic CVS effect. 1076 Chapter 39 Anesthetic Emergencies Aspiration Risk Factors. Full stomach delayed emptying. Many causes, including opioids, recent trauma, DM, CKD, known reflux, raised intragastric pressure, intestinal obstruction, pregnancy, laparoscopic surgery, anesthesia, topically anesthetized airway, LMA, especially first generation. Light anesthesia, oral nasal surgery where coroner's clot may be aspirated from nasopharynx on extubation. Steep Trendelenburg position. Diagnosis: clinical, auscultation may reveal wheeze and crepitations, CXR, diffuse infiltrative pattern, especially in the right lower lobe distribution but often not acutely. Immediate management: avoid AGA in high-risk situations. If possible, use of an RSI when appropriate, administer 100% O2, and minimize the risk of further aspirate contaminating the airway. If light anesthesia, suction and put into recovery position. If under GA, suction, consider securing the airway with at plus or minus cricoid pressure. Controversial: avoid if actively vomiting, as risk of esophageal rupture or when it distorts the view on laryngoscopy. Subsequent management: empty the stomach with a large bore NGT prior to extubation, monitor respiratory function and arrange a CXR. Look for evidence of edema, collapse or consolidation. If SpO2 remains 90%, despite 100% O2, there may be solid food material obstructing part of the bronchial tree. Consider performing a bronchoscopy. Condition: chemical pneumonitis, foreign body obstruction and atelectasis. Presentation: DSPO2, IRR, IHR, D. Lung compliance. Immediate action: minimize further aspiration, secure the airway, suction follow up action 100% O2 and consider CPAP. Empty the stomach. Investigations: CXR, bronchoscopy. Also consider pulmonary edema, embolus. ARDS. Aspiration 1077. If maintaining SpO2 with minimal requirements, extubate. May require post-extubation CPAP and chest physiotherapy. Refer to ICU if requiring support or concern regarding solid material in airway. Other considerations: the NAP4 audit found that aspiration was the leading cause of airway-related mortality. The risk was high, greatly for higher ASA status and emergency surgery. Thus, thorough preoperative assessment and appropriate planning are pertinent to reduce the risk. Corticosteroids may modify the inflammatory response early after aspiration, but do not alter the outcome, except by potentially interfering with the normal immune response. Prophylactic antibiotics are not generally given routinely unless infected material aspirated, but may be required to treat subsequent 2 degrees infections. If the gastric aspirate has been buffered to pH 7, the resulting aspiration pneumonitis is less severe, volume for volume, than if it is highly acidic. However, solid food material can produce prolonged inflammation, even if the overall pH is neutral. Consider aspiration of a blood clot in patients undergoing intraoral procedures with difficult ventilation and lack of capnograph trace. This is potentially life-threatening. Bronchial suction, exchange of airway, reintubation and bronchoscopy may be required to remove the clot. Further reading: Cook T., Woodall N., Frerks et al. Aspiration of gastric contents and of blood. In 4th National Audit Project of the Royal College of Anaesthetists and the Difficult Airway Society. Major complications of airway management in the United Kingdom. Report and findings. Chapter 19, pages 155-64.1078 Chapter 39 Anesthetic Emergencies Severe bronchospasm Risk Factors, asthma, particularly with previous acute admissions, especially to ICU, and/or systemic steroid dependence, pediatric. Prematurity and LBW, trigger exposure, smoke, allergens, intercurrent respiratory tract infection, carinal irritation by ET. Diagnosis: airway pressure, expiratory phase of capnography waveform, central trachea, with bilaterally hyperexpanded and resonant lung fields plus or minus expiratory wheeze, absent if severe. Severe bronchospasm is a diagnosis of exclusion. The quickest method of ascertaining the source of airway resistance is to connect a self-inflating bag directly to the ET, not HME, and manually ventilate. If the inflation pressure still feels too high, the problem is due to airway ET obstruction or reduced compliance. Eliminate ET obstruction by passing a suction catheter. Perform gently to prevent further bronchospasm via carinal irritation. Immediate management ABC, 100O2, increase the volatile agent concentration. Sevoflurane is the least irritant and is less likely to precipitate dysrhythmias in the presence of hypercapnia. However, this may be insufficient in severe bronchospasm. Specific treatment: salbutamol and aminophylline. Presentation: airway pressure sloping expiratory capnograph trace wheeze or silent chest IHR. Immediate action: 100O2 salbutamol 250 micrograms IV 2.5 mg neb, aminophylline 250 mg slow IV, magnesium sulfate 2 grams IV. Follow up action: hydrocortisone 200 mg. Investigations: CXR. ABG. Also consider breathing circuit obstruction, kinked at cuff hernia. Severe bronchospasm risk factors: asthma, presentation: airway pressure sloping expiratory capnograph trace wheeze or silent chest IHR. Immediate action: 100O2 salbutamol 250 micrograms IV 2.5 mg neb, aminophylline 250 mg slow IV, magnesium sulfate 2 grams IV. Follow up action: hydrocortisone 200 mg. Investigations: CXR. ABG. Also consider breathing circuit obstruction, kinked at cuff herniation, endobronchial intubation, tube migration, foreign body and airway anaphylaxis, pneumothorax. Severe bronchospasm 1079. Subsequent management: if immediate treatment fails, consider ipratropium bromide, adrenaline IV boluses, ketamine or magnesium, give hydrocortisone, check for drug allergies to agents already administered, arrange CXR, check for pneumothorax and ET tip position. Withdraw if carinal, check ABGs and electrolytes. Prolonged use of Greek letter beta-2 agonists causes hypokalemia, refer to ICU. Other considerations: gas trapping, intrathoracic pressure may result from IPPV in the presence of expiratory time. If pulse pressure falls and neck veins appear distended, consider obstructed venous return and a dependent fall in CO. Disconnect the ET from the circuit and push on chest. Preload should be restored as intrathoracic pressure is D, and pulse pressure and VT should improve. Ventilator settings in bronchospasm: 100% O2, low RR and prolonged expiration, except IETCO2, provided SpO2 is adequate. Permissive hypercapnia. Pulmonary edema risk factors: condition: I hydrostatic pressure, I vascular permeability, D plasma colloid, osmotic pressure, negative interstitial pressure, obstructed lymphatic drainage. Presentation: pink frothy sputum, IHR, IRR, DSPO2, ICVP. IPAOP. Immediate action: 100% O2, sit up, reverse Trendelenburg. Opioids, diuretics and vasodilators. Investigations: CXR, ECG, ABG, echocardiography. Also consider asthma, MI, ARDS, aspirocyan anaphylaxis. 1081. Anaphylaxis risk factors: IV administration of the antigen. Note that cross sensitivities with NSAIDs and muscle relaxants mean that previous exposure is not always necessary. True penicillin allergy is a reaction to the basic common structure present in most penicillins, the Greek letter beta-lactam ring. Antibiotics 46%. Muscle relaxants, 33%, chlorhexidine, 10%, and patent blue are the most frequent triggers. Diagnosis: CVS collapse, 51%, erythema 45%, bronchospasm, 40%, rash, 13%, angioedema, 12%, urticaria 8.5%. Immediate management ABC: stop any potential triggers, particularly IV agents. Be aware of chlorhexidine-coated central lines, call for help. 100% O2. Maintain the airway and consider intubation. Lay the patient flat, with the legs elevated Trendelenburg position. Give adrenaline in IV increments every 1 to 2 min. Alternatively, give adrenaline IM, repeated after 5 min. If necessary, give IV crystalloid fluids 20 ml kg. Condition immunoglobulin-mediated type 1 hypersensitivity reaction to an antigen, resulting in histamine and serotonin release from mast cells. Condition immunoglobulin-mediated type 1 hypersensitivity reaction to an antigen, resulting in histamine and serotonin release from mast cells and basophils presentation IHR, DBP, rash, wheeze. Edema immediate action remove trigger 100 O2. Elevate legs and fluid resuscitation IV adrenaline 20-50 micrograms follow-up action chlorphenamine 10-20 mg hydrocortisone 100-300 mg investigations plasma tryptase, directed allergy testing. ABG also consider airway obstruction asthma tension pneumothorax anaphylactoid reaction sepsis histamine release atracurium, cardiogenic SHOC 1082. Anaphylaxis follow-up investigation of reactions referral to anesthetic allergy clinic referral to an allergy clinic is the responsibility of the anesthetist and should include, anesthetic chart, drug chart, timings of all administered substances, tryptase results and timings. A list of specialist clinics is available on the British Society for Allergy and Clinical Immunology website mbsasi.org. Serum tryptase evaluation. Tryptase is a neutral protease released from secretory granules of mast cells during degranulation. In vivo half-life is 3H, compared with 3 minutes for histamine, and it is stable in isolated plasma or serum. Take 3 venous blood samples, immediately after resuscitation, at 1-2H, not later than 6H, and baseline levels at 24H. Serum should be separated and stored at -20 degrees Celsius and sent to an appropriate laboratory. Basal plasma tryptase concentration is usually 11 nanograms ml. Levels of up to 15 nanograms ml are seen in pseudoallergy, e.g., anaphylactoid reactions. In patients with low baseline tryptase levels, even if levels remain within normal limits, a level of 2 nanograms ml plus 1.2x baseline is indicative of anaphylaxis. Radioallergosorbent CAP tests, radioallergosorbent tests, RASTs, for antigen-specific immunoglobulin E antibodies have now been largely superseded by the CAP system, FADIA registered sign, currently, only helpful in confirming penicillin, succinylmethonium, chlorhexidine and latex chlorhexidine and latex allergy. Sensitivity is low, and a negative result still requires skin testing. Skin testing, diagnosing an AADR depends on skin prick test or intradermal testing. In proven neuromuscular blocking drug anaphylaxis, no in vitro test has been shown to have comparable specificity and sensitivity. Tests should take place at 4-6W post event to allow the regeneration of immunoglobulin. Antihistamines should not have been given within the last 5D. Testing is required to all drugs given before the event. Remember antibiotics, latex, chlorhexidine and lidocaine, if mixed with propofol. Suspected LA allergy is best tested by challenge. Negative control is with 0.9% sodium chloride to exclude dermographia. Positive control is with a commercially available histamine solution. The latter demonstrates a normal skin response. Wheal and Flare give a reference for reactions to test drugs. Wheal, 2 mm wider than the 0.9% sodium chloride control is interpreted as positive. Positive test with undiluted drug is repeated with 110 dilution to reduce the chance of a false positive anaphylaxis. Follow-up 1085. Following a positive result, other drugs in the same pharmacological group are tested. In neuromuscular blocking drug allergy, up to 60% of people may be sensitive to other relaxants. If there is a strong history, but negative skin prick test, diluted drugs can be tested by intradermal testing. After testing, the patient should be informed and given a letter describing the reaction and potential triggering agents used until testing is completed. An allergy alert should be added to the case notes, and treating GP Anesthetist and proceduralist surgeon informed. Patients may consider wearing a medical alert bracelet. Report the reaction to medicines and healthcare products regulatory agency, MHRA, yellow card system. AADRs are currently underreported. Future anesthesia. Avoid all untested drugs related to the original culprit. Do not use IV test doses. This is unsafe if a true allergy exists. Further reading resources regarding